What is the routine antenatal checkup that is expected? Mic la pesno. All have to hear. Otherwise, it is difficult. சும்மாவே தூங்கின்னு இருப்பாங்க.
In every antenatal visit, they have to.
No. I'm not asking about. I'm asking the schedule of antenatal visit.
Ideally 13 visits, ma'am, and then according to our government, at least 4 antenatal visits are required. 4
is WHO. Okay, 4 minimum 4 is WHO. That was told earlier, maybe a few years ago. Okay, but now they have revised because we are seeing lot of fetal growth restrictions. Okay, so adalla ninga romba pesave kudadu. Exam, let's see, this is a sort of mock exam, like that we will conduct, okay? So, we should not talk much at all. In the pakkam vandalla ipdi ninnu poma va, we should not talk much at all. Ninga vande what you are very clear, you should talk. Ipo ethan schedule keta schedule da sollum. Appo once a month till 28. Na enna sonna mundiye sollirkenla, maasa kanakku kadayadu. Pregnancy only weeks. So once a month, Gokul come. So once a month till 28 weeks. Then once a fortnight till
32 weeks.
சரி, schedule போன தடவையே படிக்க சொன்னேன்ல, போய் பாருங்க. So anyway, see whatever, because if you keep on feeding, you will never learn. You have to be very clear about the schedule which is prescribed. And when it is 37 weeks, 6 days, she should have attended the 36 weeks. So you cannot say 1 month ago. சரியா? ஆனா 1 monthக்கு முன்னாடி இருந்து BP இருக்கா? Okay.
No history of diminished urine output, no history of diminished fetal movement, no history of headache, no history of visual defect, giddiness, epigastric pain, vomiting, no history of abdomen pain, no history of bleeding per vagina, and no history of draining per vagina. Menstrual history, she attained menarche at the age of 15 years, regular cycle, 5/28 day cycle, changes 3 to 4 pads per day, not associated with clots and pain.
Again, you have to mention the LMP here. Okay.
Marital history, married since 3 years, married at 25 years, non-consanguineous marriage. Present pregnancy, first trimester, history of spontaneous conception, pregnancy confirmed after 40 days of amenorrhea.
See, you should say when she conceived. Okay, this is her first pregnancy, second. Okay, so she spontaneously conceived after so many months of married life. சரியா? அப்பதானே தெரியும். See, it can be prolonged over 2 years. I told you all, isn't it? So you should say when she conceived. Okay.
Pregnancy confirmed after 40 days of amenorrhea by urine pregnancy test. Booked and registered.
Where? By whom? So self. So you will say pregnancy confirmed at 40 days of amenorrhea with urine pregnancy test done at home or done by self, done by the patient. You should be very clear, because when they go to PHC also, whatever they say, they will again repeat. So sometimes patients first time pregnancy is confirmed only in the PHC. So everything, if you are clear, they will understand that you all are very clear in your concepts. Interfere panna matanga presentation.
Booked and registered at Valayampur PHC, antenatal card maintained. No history of excessive nausea and vomiting, dizziness, pain abdomen, fever, palpitation, convulsion and burning micturition. No history of pedal edema, blurring of vision, headache.
See, when you say excessive nausea and vomiting, did she have vomiting then? If she has not had nausea or vomiting earlier, you can say no history of nausea or vomiting. You understand? Then they will go into hyperemesis. They will start asking about that. Why should you unnecessarily give way for all that?
No history of pedal edema,
No
blurring.
history of swelling of legs.
No history of swelling of feet, blurring of vision, headache, bleeding per vagina and leaking per vagina, breathlessness and fatigability. Investigation, blood group is B positive, hemoglobin is 10.5 gram per deciliter, urine sugar and albumin is negative, ma'am. Dating scan done at 9 weeks and NT scan done at 13 weeks. HIV, VDRL, malaria test is negative, ma'am. Folic acid supplementation is given. Taken. Second trimester, quickening felt at 5th month. Anomaly scan at 20 weeks.
So, what does that hemoglobin tell us?
Anemia, ma'am.
So, what type of anemia? I mean, anemia. So, you will say mild anemia. Okay. Suppose the hemoglobin, this is first trimester. So, when do you say anemia in pregnancy in first trimester? Katti pesno. All should wake up.
Less than 11.
Less than 11 grams per
Per deciliter.
deciliter. The same thing, if 10.5 is in the second trimester, is it anemia?
No, ma'am.
Why? According to whom? According to WHO, it is less than 11 gram per deciliter always. But ICMR, CDC, all those, because we have physiological anemia during second trimester, then a hemoglobin of 10.5 is okay. So by that, in second trimester, she is not anemic. But then always better you just take 11 gram per deciliter. Something you remember very strongly. But second trimester, 10.5 is okay, not anemic. All that, அங்கே ஹைப்பர்டென்ஷனுக்கே போக மாட்டாங்க, இங்கே உங்களை கொஸ்டின் கேட்டு அனுப்பியே விட்டுருவாங்க.
Anomaly scan done at 20 weeks. Booster dose of TD was taken. No history of fatigability, breathlessness and palpitation. Iron and folic acid and calcium tablets taken regularly. No history of blurring of vision, headache, abdomen pain, swelling of leg. No history of polyuria, polyphagia and polydipsia. No history of abdomen pain. No history
This polyuria, polydipsia, polyphagia only in over diabetes. Okay. Generally in gestational diabetes mellitus, which occurs a bit later, you do not have that much high blood sugar usually. There are always exceptions. So in the idella vandu frequency of urination is a sign of symptom of pregnancy, especially in the first trimester and third trimester. Okay, but other things might probably not be there, unlike other non-pregnant women.
Investigation, hemoglobin is 11.2 gram per deciliter, weight gain is 5 kg and OGTT was found to be normal. Third trimester, able to pursue fetal movements, no history of headache, no history of pain abdomen, no history of bleeding per vagina and draining per vagina. USG done at 7-month growth scan. Patient was diagnosed to have hypertension before 35 days and she is on treatment labetalol 100 mg OD, ma'am.
What is the dose of labetalol, ma?
100 mg.
No, kindly speak loudly.
100 mg, ma'am.
100 mg eppo?
OD, BD.
Never OD, ma. It is a BD dosage. It is a 100 milligram BD. Ida start pannanum. Puriyudha? OD ella start pannave kudad. Okay. They have started. That is a different thing. But you should know what is the protocol.
Hemoglobin is 12.8 gram per deciliter. Weight gain is 7 kilograms. Past obstetric history, first pregnancy, spontaneous conception 2 years ago, booked and immunized at Valayampur PHC at 6 weeks, iron and folic acid was taken, cesarean section was done at term with indication for medically low IQ.
Medically low IQ na எனக்கு புரியல. யாருக்கு low IQ?
mother.
நீ மதர் மென்டலி சேலஞ்ச்னு இதுக்கு முன்னாடி எப்பவா சொன்னியா? சொல்லவே இல்லை. யூ ஷுட் ஹவ் டோல்ட் ஆல் தட் earlier. யூ ஃபாலோ மீ. ஓகே. No, what is she actually? What is the problem with her? You have seen the patient?
Yes, ma'am.
Okay, what is wrong with her?
She's not able to respond. The patient was not able to respond properly. It was her attendant who gave all the.
But otherwise, her emotion, everything is fine.
Everything is fine.
Okay, just mentally challenged.
Yes, ma'am.
That is how you say. Okay. Okay. For that, why was C-section done?
She unable to push baby.
வலி வந்தா தானா வெளியே வரும்பா என்னன்னாலும். அந்த அளவு வலி, லேபர் பெயின்ஸ். நீங்கள் வாட்ஸ்அப் பார்க்குறீங்கல்ல, எத்தனையோ போன்ஸ் உடஞ்ச மாதிரி பெயின்னு சொல்லிட்டு. ஷி வில் நாட் கோஆப்ரேட்னு மக்களே எடுத்துட்டாங்களா? அல்ல அட்டெண்டர்ஸ் would have asked. No, who decided she should have section?
It was the doctors, ma'am. They didn't try for normal vaginal delivery. They went for cesarean
Elective
section.
C-section.
Yes, ma'am.
So they decided she might not be cooperative. This is ideal for her. So
They went for
sometimes mentally challenged women can be quite aggressive. Okay, சும்மாவே லேபர் பெயின்ஸில் நம்ம கையை பிடிச்சி நசுக்கி எடுத்துருவாங்க. They will nowadays people are a bit more better. Earlier nicely they will pinch us, they will beat us. We never used to leave attenders initially. Birth attendant concept came later. Okay, that time we used to think we should never leave any attenders inside. Okay, so so whatever it is, all the parents also of the girl would have asked, so many things are there. Okay, so India, okay, suppose if the parents had asked for C-section, what is it called?
Elective cesarean.
What do you mean by elective?
Elective, it is not emergency, it is scheduled.
இது என்னது? Not an elective is a planned C-section. Emergency, you just decide suddenly and take up. This will be a cesarean section on maternal request. Maternal request, Alana, if she is not able to give consent, it is the attenders who will be giving consent for her, since she is mentally challenged. So it is called as C-section on maternal request. You have to tell the indication like that. But here maybe the obstetrician decided that we will, okay.
Otherwise uneven full pregnancy. First child, female baby, birth weight of 3.2 kg, cried immediately after birth, breastfed within 1 hour of birth. Family history, no
இல்ல அதையே முழுக்க சொல்லி முடிச்சிரேம்மா. That you are going to tell later, how long she breastfed. அந்த கான்ட்ராசெப்டிவ்ஸ்ல இங்க வராதா, அப்புறம் வருதா? No, I'm just asking. It's not. What I would suggest is, see, once you told about the first pregnancy, why don't you tell how long the baby was exclusively breastfed, how long, and whether she was on any contraception. You can finish off, you will never forget. On அப்படியே ஒரு ஃப்ளோவா சொல்லி முடிச்சிடலாம்.
Family history, no significant family history, ma'am. Past history, no.
So twin pregnancy னு சொல்லக்கூடாது, multiple pregnancy. Okay.
Past history, no history of diabetes, hypertension and TB, asthma, epilepsy, rheumatic heart disease and jaundice. History of low IQ since childhood. Cesarean section was done in first pregnancy.
So you should have asked the attenders whether her milestones were normal. Since childhood she has had a low mentation. That is fine. But whether her attender அம்மா கூட இருந்தாங்கன்னா நீ கேட்டிருக்கணும். That is all important, whether it was since birth.
No history of bleeding disorders and no history of blood transfusion was done. Personal history, consume mixed diet, normal bowel and bladder habits, a normal sleep pattern, no history of smoking and alcohol, maintains personal hygiene.
That means she is fairly mentally okay.
Yes, ma'am.
Okay.
Summary, 28-year-old, gravida to para 1 live 1, belonging to lower middle class, booked and immunized at Valayampur PHC with last menstrual period of 5/6/2024, expected delivery date of 12/3/2025 with 37 weeks plus 6 days of gestational age, referred from PHC for elevated blood pressure 120/90 mmHg in 7 months of amenorrhea, was on regular medication, referred for further evaluation and management.
Okay.
General examination, the patient was conscious, comfortable, cooperative, oriented, moderately built and nourished. No pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, no pedal edema. Gait was waddling gait. The pre-pregnancy weight was 68.4 kilograms. During pregnancy, her weight currently is 81 kilogram. Height is 160.
More than that, have been repeated. Now you can say 81 kg. But what is important is a weight gain. எங்களுக்கெல்லாம் நம்ம மெடிசனே வர்றது மேக்ஸ் கொஞ்சம் நம்மளுக்கு உதைக்குதுன்னு ரிலேட்டிவ்லி சரியா அப்படி இருக்கும்போது in this age if you want us to calculate it's difficult. So weight gain in this pregnancy அப்படின்னு தெளிவா சொல்லணும்.
12.6.
12.6. So that is fair enough. Okay.
Height is 160 centimeter and the BMI is calculated to be 26.7 overweight.
Okay. But then a patient who is overweight, when do you say a woman is overweight?
More than 25 BMI.
More than 25 is generally. We are all Asians. Okay. So 22.9 வரைக்கும் தான் நம்மளுக்கு வந்து normal BMI. 18 to 22.9. 23 and above, we are all overweight. So when we are overweight, generally what is the weight gain which is accepted?
9 to 11 kilograms.
Okay. So around that. Here, if she gains about 8 kg, 9 kg max, that would be fine. She has already gained 12 kg. So actually our calculation of expected weight gain in a particular pregnancy, we have to decide in the first visit itself by calculating the BMI. I think last time itself I told you all to go and read up about Institute of Medicine, okay, weight gain in pregnancy. So how much weight gain should be there? Suppose she is very obese, then a weight gain of 5 kg would be adequate. Okay, so you cannot say 12 kg means she will develop diabetes, she will develop hypertension, all sorts of big baby, all sorts of things. Okay, so our weight gain depends on the initial BMI. Okay.
Vitals and system examination. She was afebrile. Pulse rate was 79 per minute. Blood pressure was 110/90 mmHg. After 4 hours, her blood pressure was 110/80.
Why did you see after 4 hours?
We have to check her blood pressure in 2 occasions, 4 hours apart. For
see, that is for diagnosis. See, initially, when you label a patient as a hypertensive disorder of pregnancy, that is something because she automatically becomes high risk. You do not wait for so many things in view of maternal and fetal well-being. But then, initially for diagnosis, you have to be cautious. Once diagnosed, no need to keep on repeating unless you have high blood pressure. Suppose her BP is 160, 120. You have given something. Then probably 15 minutes you can repeat. So for diagnosis, you need at least 2 BPs of 140 by 90 millimeter mercury or more 4 hours apart. Okay, not for this. You understand my
ma'am.
point? Pa ஒருத்தருக்குமே எதுவும் டவுட் வரலையா? Okay.
System examination, CVS, S1, S2 heard.
See, it should be interactive. Anything, any doubt if you ask, so many will have that. But they will be a bit reluctant to voice their doubts. Okay? You will be helping many if you get up and ask anything, if you have a doubts.
RS, normal vesicular breath sounds heard, no added sounds. CNS, no focal neurological.
What is the significance of physical examination of other systems in this patient? She is a hypertensive disorder of pregnancy.
So we can have cardiovascular complications
What?
during CCF. Patient.
So it is a left ventricular failure essentially. Unlike other things where you have right ventricular failure, this is because of the hypertension. Okay, what about RS?
Patient can go for edema.
Pulmonary edema. So all these things, suppose a BP had been, it is only 110/70 he said later, isn't it? But then if she has some crackles, probably it is pulmonary edema. Okay, then in that event it will become severe preeclampsia, although the BP is controlled. So involvement of any preeclampsia itself is a multi-system disorder. So if any system is involved along with the hypertension, even if the hypertension is well controlled or very mild, you call it severe hypertensive disorder of pregnancy, you have to decide about termination of pregnancy or any other event. She should be strictly, closely monitored.
Abdominal examination, after obtaining verbal consent, after emptying the bladder, patient in supine position.
After asking the bladder to, after asking the patient to empty her bladder, that is much better. அப்ப தெளிவா அல்லனா உடனே கெத்திட்டு போடுவியான்னு கேட்பாங்க. தேவையா?
Semiflex leg exposed from xiphisternum to pubic symphysis.
Dorsal position.
Inspection, abdomen longitudinally distended, flanks full, umbilicus flush to skin and everted, linea nigra seen, stria gravidarum seen.
After verbal consent munadi, after explaining the procedure to the patient and getting verbal consent for examination of her, அப்படின்னு சொல்லிட்டீங்கன்னா complete ஆயிரும். You are supposed to explain the, நான் கொஞ்சம் பார்க்க போறேம்மா, ட்ரெஸ்ஸை கொஞ்சம் எடுத்து இப்படி வயிறெல்லாம் பார்க்க போறேன், அதெல்லாம் சொல்லணும்.
Previous cesarean scar which is healthy, no sinus, no dilated veins, perineal orifice is free.
So you have to you have to say previous cesarean scar seen on the suprapubic area. So it is whether it is a vertical or transverse scar ங்கிறத நம்ம சொல்லணும். See, it can be a transverse scar, it can be a vertical scar. Okay, so other சொல்லிட்டீங்கன்னா a suprapubic transverse scar of about 10 centimeter, 12 centimeters seen which is healthy. Okay, then in that event we know it is a transverse, the incision had been transverse. Okay.
On palpation, fundal height corresponds to 36 weeks of gestation, fundal grip, broad, soft, non-independently ballotable, suggestive of fetal breech, umbilical grip, left side, smooth curvature, uniform resistance felt, probably fetal spine.
Why you all are late, ma? Huh? Phase 2, okay.
Right side, multiple small nodules felt, probably limb butts. First pelvic grip, hard, round, independently ballotable.
Small, hard, round mass. Ada சொல்லணும். Small தானே இது. Small, hard, round mass, independently ballotable of the body.
felt at the lower pole of the uterus, probably the fetal head. Auscultation.
You
fetal-
have to say second pelvic grip. The findings of the first pelvic grip was, yeah, you need not assess the CPD, all those things. But then when you have to say the findings of the first pelvic grip were confirmed. That means only head is in the lower pole. Okay.
Auscultation, fetal heart sound.
In second pelvic grip, how do you identify that it is head?
If the hands converge, then we say it is unengaged head, ma'am.
நான் அன்எங்கேஜ்னு கேட்டேனா ஹெட்டா இதுவான்னு ஹெட்டுன்னு எப்படி தெரியும்?
Bellotable.
செகண்ட் பெல்விக் கிரிப்ல பெலோட்டபிள் பார்ப்பீங்களா? See, first pelvic grip, you see whether the head is bellotable. First pelvic grip, you are standing on the right side of the patient, facing the patient's face, and வர சொல்லலாம் எட்டி எட்டி பார்த்துட்டு இருக்கு. So you, for second pelvic grip, you face the feet of the patient. Patient காலை முதல்ல இவ்வளோ மடிச்சிருக்கு இல்லையா, கொஞ்சம் இறக்கிட்டு, not fully, கொஞ்சம் இறக்கிட்டு, you face the feet of the patient, then என்ன கொஞ்சம் பிடி. So what you do is, this is the back on one side, this is the limbus on the other side. So backல இருந்து கீழே வரணும். வந்த உடனே first bony point is the occiput. The opposite bony point is the sinciput. So that is how you confirm the findings of the first pelvic grip. Suppose if it is breech, then you will not have that. But then an extended breech. What do you mean by உங்களுக்கு மைக் கொடுக்கலையே மக்களுக்கு? What do you mean by extended breech, ma? Ma, last girl. எழுந்து நில்ல. No, the girl behind you. Oh, second years, I mean, juniors. Okay, ma. நீ எழுந்து கோப்பா. What do you mean by extended breech?
Positioned at the
Pardon?
baby is positioned at the bottom.
Ah.
Bottom first.
So buttocks, that is what we say. Okay, okay.
With leg extended. At
With the
legs extended.
neck,
Leg.
leg. So இந்த மாதிரி பாப்பா இப்படி இருக்குன்னா, okay, the whole thing, leg is gone like that. Suppose if it is flexed breech, எல்லாமே flexed இருக்கும். Universal attitude of universal flexion இருக்கும். So the leg will be extended like this. So head will be splinted in between. So நீங்க மேலே பார்க்குறச்சேயும் மொபைல் ஹெட்டாகவும் சில சமயம் தெரியாது. So this is one thing which you have to always keep in mind. Okay, when you have an extended breech, that will be compact also. இப்போ மற்ற flexed breechல broad இருக்கும், இது கொஞ்சம் compact தான் இருக்கும், more or less. Okay, I would like you all to close the books, ma.
Auscultation, fetal heart sound is felt at left spino-umbilical line. At rate is
What do you mean by spino-umbilical line?
The midpoint between the fetal spine and the umbilicus of the mother. Anterior superior.
Maternal anterior superior iliac spine and the umbilicus of the mother. Maternal தான். Spino-umbilical line na fetus ko adukku sambandham kadayadu. But you will see the fetal heart, we know what mistakes students will make. அதுக்கு தான் நாங்கள் வந்து நீங்கள் நேவா you have to present. We will whatever it is so that all understand. Okay, so but you will see where the fetal spine is there. So heart will be near that. Suppose the spine is here. Okay, fetal spine is here. Then you will see the right spino-umbilical line. If the spine is on the left side, then the left spino-umbilical line. Okay.
Rate is 120 to 140 per minute, regular in rhythm. Diagnosis, A 28-year-old Gravida 2, Para 1, Live 1 with previous full-term cesarean section for a recurrent indication 2 years back with 37 weeks, 6 days of gestation age, has a singleton live fetus in cephalic presentation, longitudinal lie with good fetal heart sound and not in labor, is diagnosed as a case of gestational hypertension complicating pregnancy with no other medical, obstetric or surgical complication, came for institutional evaluation and management.
No other medical or obstetrical, okay. So how will you manage this patient?
First we'll do investigations.
Okay.
We'll start with investigations.
No, you should tell me first with any patient whether you will admit, you will do investigations, then only treatment. But then you will also tell me whether you will admit the patient or not. All that is important. She just came for checkup, isn't it?
This patient we don't need to admit, ma'am, because
Pardon?
This patient we don't need to admit, ma'am, because
why?
The blood pressure is 110/80 when we check.
Okay.
And she's under medication, so
Under medications, probably I will find out. எனக்கு இந்த பிஹெச்சி இந்த our வீடு எங்கே இருக்குன்னு தெரியாது. Whether she is in a position to access care, because it is now term pregnancy. So if you say 37 weeks, 6 days, you are justified in admitting the patient. Okay. Other patients, probably not all gestational hypertension, you control them, you discharge them on medications, you tell them how to get themselves monitored with BP, ask them to come for review every week, then you just do the blood investigations too, that is fine. But she is 37 weeks, 6 days, post-cesarean pregnancy. You will be wrong if you say, I will treat her as OP. You follow my point? Okay. We have to decide about termination of pregnancy, isn't it? You have to get fitness for that, all these things. Okay.
Investigations, CBC, peripheral smear, hemoglobin, blood urea, sugar, serum creatinine, urine analysis, we'll check albumin.
See, you took this case from Tiruvannamalai Medical College. Okay. Do they do hemoglobin there?
They don't do CBC. They don't do CBC.
They don't do CBC.
That is what Arunai ma'am told.
நீங்க வார்டுக்கு நீங்க எத்தனை நாள் போஸ்டட் அங்க?
28 days.
20 days. 20 days போனியா ஒழுங்கா?
Yes ma'am. Yes ma'am.
Okay, fine. நீங்க வந்து கேஸ் ஷீட்லாம் பார்க்கலையா? What do you mean by அருமை என்ன சொன்னா?
CBC generally pregnancy they won't check because there will be a lot of deviation, so
no, that's wrong. See, we are even in a PHC. Tamil Nadu is one place where successive governments are taking lot of care to see to that semi-calorie meters are given where CBC comes out. அதுக்கப்புறம் மெயின்டைன் பண்ணுறது அந்தந்த இன்ஸ்டிடியூஷன் ஹெட்டோட பொறுப்பு. எப்போவோ கொடுத்தாச்சு, அதுக்கப்புறம் மெயின்டைன் பண்ணலன்னா தட் இஸ் பிகாஸ் ஆஃப் அஸ், ஆல் ஆஃப் அஸ். நம்ம யாரையும் குறை சொல்ல. அண்ட் வி ஷுட் see to that we get CBC because PCV is very very important for this patient. ஹெல்ப் சிண்ட்ரோம் அதிலெல்லாம் வந்து கான்சன்ட்ரேஷன் ஹீமோ கான்சன்ட்ரேஷன் வரும். So for anemia varum, okay, but then all these things you have to remember. Anemia, type of anemia, when I took anemia class for you, I told you all. நீங்க போய் யாராவது பாத்தீங்களா உங்கதுல ஹீமோகுளோபின் பண்றீங்களா சிபிசி பண்றீங்களான்னு பாத்தீங்களா?
ரிப்போர்ட்ல சிபிசில ஹீமோகுளோபின் இருக்கும். ஹீமோகுளோபின் இன் சிபி
அது இருக்கும். அதான் கேக்குற, சிபிசி பண்றீங்களா ஹீமோகுளோபின் பண்றீங்களா தனியா? CBC. So that is the norm everywhere. Illana, we have to make it. We should know what are the physiological changes, alter it accordingly. CBC is the basic gold standard. புரியுதா? எப்போவோ கொடுத்தாச்சு எல்லாத்துக்கும். நம்ம அதை ஃபாலோ பண்ணலன்னா all of us are like that. இவ்வளோ பெரிய பில்டிங் வெளியே என்ன அந்த இதில் என்னமோ கரையாக இருக்குது. Because none of us bother to maintain things. That is the reason.
Blood grouping and typing.
Urine என்னமோ சொன்னீங்க.
Albumin, sugar and 24-hour urine protein.
24 hours urine protein பண்றீங்களா?
No.
Then why do you say?
General invis.
General. What you should do for that? Huh? Kindly speak into the mic.
Protein creatinine and
Then
ratio.
you tell that. That is available. நாங்கெல்லாம் ரொம்ப நாளைக்கு முன்னாடியே இருந்ததப்பா. நம்ம எல்லாம் டிட்டரேட் பண்ண விட்டா we are all like that, all of us. I am not finding fault, I am just lamenting, that's all. ரொம்ப வருத்தமாக இருக்குது. பட் ஹெட்டு தான் அக்கறைப்பட்டு திங்ஸை பிடிச்சி வாங்கணும். nobody will like if we are particular about things. But then these are all mandatory. 24 hours urine protein நான் சீனியர் அசிஸ்டண்ட்டாக இருக்கும் போதே போயிடுச்சு. யாருப்பா உட்காந்து 24 மணி நேரம் யூரின் கலெக்ட் பேஷண்ட்டுக்கும் டார்ச்சர், அதை எடுத்துன்னு போகிறவங்களுக்கும் டார்ச்சர். கொண்டு ஹாஸ்பிட்டல் ஒரு இடத்துல இருக்கும், லேபெல்லாம் ஆப்போசிட் சைட் மெடிக்கல் காலேஜில் இருக்கும். ஜென்ரலி கவர்மெண்ட் இதில் அப்படி தான் ரோடை கிராஸ் பண்ணி கொண்டு போய் கொடுக்கணும். ப்ரோட்டீன் கிரியேட்டினின் ரேஷியோ ஏர்லியர் அவங்க நம்ம எக்ஸாமினர்ஸ் கேட்டாலும் யூ ஷுட் பி கான்ஃபிடென்ட் டு சே earlier we were doing 24 hours urine protein, now we do not do it anymore. It is protein creatinine ratio. சரியா?
Dipstick can we do?
என்னம்மா?
Urine dipstick.
அது வந்து ஆல்புமின்ல வந்துரும் இல்லப்பா. Albumin sugar deposits. Madam, and I think you have misunderstood Arunai. என்ன சொன்னாங்க மேடம்?
In government college it is CBC is taken, ma'am, but generally during the first class she told CBC there'll be deviation, so you should not depend on CBC like completely. That's what she told.
Yeah. கவர்மெண்ட்ல பண்றாங்க, அப்ப பிரைவேட்ல இன்னும் பண்ணணும்ல.
Yes, ma'am.
பேஷண்ட் பே பண்ணதில்ல, பண்ணணும்ல. பிஹெச்சில பண்றாங்க, அப்ப மற்ற இடத்துல பண்ணணுமா இல்லையா?
Yes, ma'am.
ஓகே.
HIV, VDRL, HVS.
இல்ல BTCT தேவையா? What do you mean by that?
Bleeding, clotting.
அது வந்து what use does it really have? Everybody writes BTCT. What is CT?
Clotting time.
How do you do it?
We have to take a capillary and
அப்பா நம்ம என்ன சொன்னாலும் எப்படி பண்ணுறாங்கன்னு தெரியணும், புரியுதா? கைண்ட்லி ஃபிசியாலஜியில் நம்ம எல்லாரும் பண்ணதானே, திருப்பி போய் படிங்க. ஏன்னா அதர்வைஸ் we will not be able to discuss the final things. Okay. Thyroid function test, okay.
HIV, VDRL, HVSAG, peripheral smear, renal function test, serum.
In peripheral smear, what will you see?
We can see schistiocytes. If the patient is going, schistiocytes, ma'am. If the patient is going for
schistiocytes, okay.
HELLP syndrome. If the patient is anemic, we can find.
Okay. Platelets also can be decreased-ங்கிறது தெரியணும். So CBC generally includes platelet counts, but certain places platelet count comes separately. So we have to specifically see for platelet count in such patients. All pregnant patients பார்த்துக்கிறது நல்லது, especially for this patient.
Renal function test, serum uric acid, serum creatinine, we have to check. Liver function test, USG abdomen and fundus examination.
USG abdomen na enna paapa?
Fetus.
Adu obstetric USG இல்லையா?
Yes, ma'am.
You have to, generally we talk about obstetric USG, but then this patient you can say USG complete abdomen along with OB USG, ஏன்னா liver ஏதாவது involvement, but அதுக்காக unless patient complains of pain in epigastrium, pain in right hypochondrium, but you should be able to justify. Then what else?
fundus examination.
Okay. Is there a role for obstetric Doppler?
Yes, ma'am.
How?
We'll
No. Why? How?
to check whether the fetal distress is present. Fetal
Why?
heart.
For that you don't need a Doppler, isn't it? See, if the baby is well grown, if Leica is adequate, movements are fine as seen in biophysical profile for which you don't need a Doppler, you don't need it. If the baby is fetal growth restricted or if the Leica is decreased, then probably you will need. You can do, but you should be able to justify. People might routinely do, that is also fine. They want to be careful. But you should know, you just cannot say USG abdomen. You follow my point?
Yes, ma'am.
What is the significance of fundus examination in this patient? Do you routinely do for all antenatal patients?
No, ma'am.
Then?
Hypertensive patient can go for hypertensive retinopathy. They can have visual disturbances. So fundal examination will rule out.
Not only that, with visual disturbances illamale, they can be even grade 4 like that. Okay, papilledema can be there. So that is the importance of all these things. Papilledema, you might have to terminate pregnancy. Suppose you do not want urine deposits. Urine deposits. என்ன உனக்கு புரியலையா? TEPOSITS.
Yes.
இல்ல, you're not following.
Renal function. Renal, if
No,
the patient has.
See, you have not mentioned urine routine includes albumin, sugar deposits.
Okay, ma'am.
Isn't it? Because you mentioned, I asked.
Okay, ma'am.
So urine routine சொல்லியிருந்தா வம்பே வந்திருக்காது இல்லையா? So granular cast can be seen in a woman who is hypertensive, probably due to renal etiology.
Management will.
சொல்ல.
Ma'am, first we'll start with anti.
So with okay, now in BTC platelet, what about coagulation profile in this patient? What is coagulation profile?
You have to check whether the coagulative factors.
What factors?
Ma'am,
ஏய் சொல்லுங்கப்பா, டக்கு டக்குன்னு சொல்லுங்க, நம்ம அப்புறம் மற்ற கேஸ் எப்போ டிஸ்கஸ் பண்ண?
ma'am, PTINR.
PT, APTT, INR, all these things are indicated only if the platelet count is less. Otherwise, there is no role for routine coagulation profile. PHC la kuda BTCT routine பண்றாங்கப்பா. Normal, so-called low risk. But I don't know, I don't believe in this because each thing costs money, costs human effort. We should not unnecessarily waste such things. So you should really know to individualize the investigation panel. Okay, so and never labetalol OD. We started 100 milligrams BD. Okay, so suppose her BP was 140/90 initially. She came to your OP 140/90. What do?
After 4 hours, we'll check.
So
the
you
diagnosis.
make that means your suspicion is enhanced that probably this can be a high risk pregnancy. So you make her wait, make her sit comfortably, repeat the BP after 4 hours. How should you actually take BP in OP?
Patient should be in either sitting position or semi-recombinant position.
OP la padukka vechiruvingala?
Sitting position.
I just asked in OP.
Sitting position.
So patient should be sitting on a chair with arms. கை இருக்கணும். ஓகே, பாதி இது கவர்மெண்ட் இதில் வந்து ஸ்டூல் போட்டுருவோம் பேஷண்ட்டுக்கு. டாக்டர்ஸ் மட்டும்தான் சேரில் உட்காந்துருப்பாங்க. ஓகே, ஹேண்ட் இருக்கணும், பேக் இருக்கணும். ஸ்டூல்னா பேக் இருக்காது இல்லையா? ஸோ அண்ட் த லெக் ஷுட் பி ரெஸ்டிங் and she should not have had coffee or tea, any stimulants which will increase the pulse rate and BP prior to that. ஒரு 10 நிமிஷம் அமைதியாக உட்காந்துட்டு then we should take BP. In government அவ்வளோ கூட்டம் இருக்கும். அப்படியே பேஷண்ட் அப்படியே இழுத்து பிடிச்சி தான் டக்கு டக்கு டக்குன்னு போட்டு போயிட்டே இருப்பாங்க. We should not do that. And they can develop increase of BP due to our white coat itself. They'll be so scared, which is called as white coat hypertension. So கொஞ்சம் அமைதியாக உட்கார வைக்கணும். ஒரு பிபி சேர்னு நம்ம ராஜாக்கு சிம்மாசனம் கொடுக்குறோம்ல, அது மாதிரி ஓபியில் ஒரு பிபி சேர்னு ஒன்று வச்சிடணும். ஸோ அமைதியாக உட்கார வச்சுட்டு we do other things and then you take a BP. Okay. And suppose when do you start antihypertensives? Okay, திருப்பி பிபி பார்க்கும்போது 140/90. So what is your diagnosis now?
Now gestational hypertension.
It is a hypertensive disorder. It can be gestational hypertension, it can be preeclampsia. Okay, so any BP raise first வந்தா நம்ம உட்கார வச்சுட்டு திருப்பி பார்த்துட்டா then we decide. Okay, so it is a new onset. When do you say gestational hypertension?
Gestational after 20 weeks of gestation, when the blood pressure is more than 140/90 in 2 separate occasions 4 hours apart. In a normotensive patient.
Yeah, in a previously normotensive patient. And when do you say preeclampsia?
When the patient, when the blood pressure is more than 140/90 and patient has proteinuria, we call
it. Can be proteinuria, or I said earlier also,
signs of
even without proteinuria, any other organ affliction. Okay, in the form of liver can get involved, where you can have abnormal liver function test, or brain can get involved where you can have visual defects, okay, or she can throw a fit, or heart can get involved where they can go in for failure. That is unlikely, last thing. Or they can have pulmonary edema. So proteinuria illanalo pulmonary edema vandiduchina, it is severe preeclampsia. Or they can have bleeding diathesis in form of prolonged PT, APTT, adala. So any system can get involved. In kidney, when do you say the kidney is involved? That is a common thing. Adanal da proteinuria paakrom.
When oliguria, when the patient presents with oliguria, we can say
oliguria is a symptom, and probably when you evaluate it is a sign to a certain extent. What is the definitive diagnosis?
glomerular endothelios.
இல்லப்பா, எப்போ நம்ம glomerular endotheliosis நீ பாப்பியா? Pedal edema does not matter at all. I told you repeatedly, 70% of normal pregnant patients, pregnant women can have pedal edema. Okay, அது வந்து ஒரு clue sort of. Earlier only we had the triad, hypertension, proteinuria and edema. Now that has been taken off since long. நான் அசிஸ்டண்ட்டாக இருக்கும் போதே அதெல்லாம் போயிடுச்சு. Now we talk about hypertension plus proteinuria or hypertension plus any other organ dysfunction. Kidney dysfunction எப்போ?
Elevated serum urea, serum uric acid, creatinine.
Uric acid-லாம் கணக்கு கிடையாது. It is elevated serum creatinine. Urea can get affected even in dehydration. ஒரு வாமிட்டிங்கில் கூட இதாகும். When do you say, what is the level?
More than 1.1.
1.1. That is important. Or double the level of previous value. What happens to serum creatinine in pregnancy?
Decreases.
It decreases. It decreases. So 0.5, 0.4 la easy-ஆ பார்ப்போம். Suppose அவங்களுக்கு வந்து 0.5 லேருந்து 1 ஆகுது. When it doubles, or if it is 1.1 milligram per deciliter or more. So that is important. We should not wait 1.2 meals andala kadayadu. Okay. So in the patient வந்து 140, 90, 2 occasions. So இப்போ என்ன பண்ணுவ? OP-ல உட்கார்ந்திருக்கா. என்ன பண்ணுவ?
Antihypertensive.
So I will admit her. I can also treat her on OP basis, but then sometimes her blood parameters can be awry. In that event, she might be labeled as severe hypertensive disorder of pregnancy. So to just know about her initial status, I will admit the patient. Okay? Admit பண்ணி என்னெல்லாம் பண்ண போற? So
BP monitor. BP monitor and then
okay, BP so இப்பதான் antihypertensives போடுவேன். So once 2 இது diagnose பண்ணிட்டோம்னா, you will start them on labetalol 100 milligram BD. What are the drugs which can otherwise be given?
Hydralazine and nifedipine.
Hydralazine. See, alpha, we were all groomed on alpha methyl dopa. 250 milligram tablet was available. It should be given as QID dosage, and that can be given. Nowadays, in Tamil Nadu government, we do not supply alpha methyl dopa. Very difficult to get in private also. 1 or 2 companies தான் பண்ணுது. ஆனால் nearby Kerala, which has the least maternal mortality in India, they use only alpha methyl dopa. They swear by that. But generally, nammadila labetalol தான். So suppose 100 milligram BD கொடுக்குறேன். அப்புறம் BP monitor பண்ணுறேன். What should be your target?
Systole should be 120 to 130 and diastole should be 80 to 90 million.
135, 85 would do. Okay? Because if we decrease the BP grossly also, then the blood flow to the baby will be decreased. So அதனால நம்ம ரொம்ப கேர்ஃபுல்லா இருக்கணும். ஸோ ஓரளவு 130, 80 அந்த மாதிரி நம்ம ஆர்சிஓஜி படி 135, 85, பட் நாட் வெரி லோ. அது நம்மளுக்கு தெரியணும். Otherwise it will affect the growth of the baby. So you are doing investigation. Urine, albumin, sugar deficit, urine culture sensitivity. Otherwise also in pregnancy, urine culture sensitivity, because any infection has to be aggressively treated, although she is asymptomatic. நல்லா குறைச்சி மற்றவங்க குளிருதுன்னு சொன்னால் கூட்டிக்கலாம். Okay, and of course grouping typing would already have been done, and he said urea creates in uric acid. Why did you do uric acid?
Cast.
Pardon?
Renal cast, urinary cast.
Here as a prognostic marker, okay, that will tell us probably about the well-being of the baby to a certain extent. Okay, otherwise mundi we gave lot of importance to uric acid, but this is one place where you do uric acid. Okay, then urea, creatinine, sugar patti sonnaya?
Yes ma'am.
Anga sonna?
Sonna. Yes.
Okay, sorry I missed. Okay, sugar eppadi pathinga?
See.
Pardon? இப்போ OGTT பண்ணீங்களா? So did you tell me that OGTT was done earlier?
Yes ma'am, in second trimester.
Second trimester. Third trimester பண்ணுமா வேண்டாமா? எப்போ பண்ணணும்? நீ கத்தி பேசு.
32 weeks.
32 weeks we should have done. Okay, especially diabetes and hypertension go hand in hand, so it's very very important. So 32 weeks la pannirundanga thevai illa if it had been normal, otherwise you have to do. So you should be able to really discuss things. Okay, so in the patient ku vandu blood investigation normal. இப்போ அவ முதல்ல எப்போ கண்டுபிடிச்சாங்க? 33 weeks 6 days அந்த டைம் தானே, 1 month earlier. So 33 weeksல வந்து we identified. Then BP is under control. Patient is fine. Then baby is well grown for the gestational age. No oligohydramnias. Then you discharge the patient. முதல்ல 33 weeksல தானே வந்தா. So you will discharge the patient, counseling her about when she should rush to the hospital. And அப்போ எப்படி வரப்போறா, நம்ம 108 எல்லாத்தையும் சொல்லணும். How they can approach us. ஏன்னா ஒரு ரிமோட் வில்லேஜில் இருந்தா, சப்போஸ் she is in Jamnamartur, அங்கேருந்து வந்தான்னா you cannot discharge her. She cannot come back. அங்க மலை இறங்கி திருப்பி ஏறி திருப்பி இறங்கி வரணும். Okay, so you should know from where she is coming. Then you should, when you are discharging her, you will tell her about the danger signs. Danger signs of pregnancy, danger signs of eclampsia. Okay, what are the danger signs of pregnancy?
Swelling of feet, vomit.
Swelling of feet நான் கண்டுக்காதன்னு சொல்லிட்டேன். இனிஷியலா ஒரு corroborative factor சொல்லிட்டேன். Then
bleeding PV, leaking PV.
Okay, any pain abdomen, decreased fetal movements, any patient when you discharge you have to tell. Okay, bleeding PV, draining PV. And what are the danger signs for her hypertensive
headache?
So what are the things?
Headache, epigastric pain and visual
வரிசையா சொல்லிட்டு வரணும். Headache, blurring of vision, nausea, vomiting, breathlessness, pain in epigastrium, pain in right hypochondrium, decreased urine output. Okay, any bleeding, diathesis. So இதெல்லாம் சொல்லி அனுப்பணும். அல்லனா குழந்தை அசறதுன்னா சரி பாட்டிமா சொல்லுவாங்க அப்படித்தான் இருக்கும், நீ தூங்குறல்ல உன் பாப்பாவும் தூங்குதுன்றுவாங்க. For PIH sometimes stillbirth can occur. Okay, so we have to tell all these things and ask her to, when will you review her? You have to inform the concerned PHC also. நீங்க private இதா இருக்கலாம், ஆனாலும் you have to inform the concerned. See, everywhere now they have a system where WhatsApp group இருக்கும். All OGCIans, both private and government are there. So if you put it in the high risk group itself, then the concerned medical officer will note, follow up this patient. அவங்ககிட்ட தான் போகணும்னு கிடையாது, நம்மகிட்ட வரும் பேஷண்ட்டை திருப்பி. But probably after 3 days again a BP will be taken at home, or they will ask her to come and take. Then she has to come to us after 1 week. You should know about the government programs too. Okay, she will come to us after 1 week. So அப்ப என்ன பண்ணுவ? So இப்போ 34 weeks.
Again BP monitor one day if it's
BP is well controlled.
We have to check whether she has any other complications.
What complications?
Like
so history you will again ask whether she perceives fetal movements well, any symptoms of imminent eclampsia. Everything is fine, no problem at all, BP is normal. Then what will you do?
Wait till
you have to repeat blood. Once diagnosed as hypertensive disorder of pregnancy, you have to repeat the blood investigations every week. Okay, suppose if it is severe, if it is admitted, you will do even within 3 days. But this patient, even if everything is fine, you have to repeat the blood investigation because BP can be normal, no albuminuria, but then she can develop HELP syndrome, which can be missed, which can be catastrophic for the mother. So it is important to do blood investigations, LFT, RFT, hemoglobin, all these things, peripheral smear, everything you have to do every visit. Okay, then what do you plan to do? Suppose இப்போ போயிட்டு, so now 34 weeksல அவ ஓபியா வந்துட்டு போயிடுறா. You ask her to come after 1 week. In the meantime, you tell her 3 days கழிச்சு பக்கத்தில் பிஹெச்சியில் போய் பிபி பார்த்துக்கோமா. BP is normal. Then at 35 weeks, she again comes. History கேட்குறீங்க, perceives fetal movements well, no symptoms of imminent eclampsia. BP is 150/100.
We have to admit the patient to 150.
Okay, you are justified if you say you have to be careful. Mortality is something which we should always think about. Okay, you admit the patient, blood test லாம் பண்ணிட்டா normal. என்ன பண்ண போற அதுக்கு முன்னாடியே? So BP is increased. So you will probably make labetalol 200 milligram BD. Okay, if it is well controlled, fine. Otherwise, you make it thrice a day. Okay, what is the maximum dose you can use?
1200 milligram.
Helpline. Okay, that is fine. Exam liyu helpline vanda sandosham da. Okay. So maximum of 2400 milligram. But generally now with 1200 milligram மேல நம்ம கொடுக்கறதில்ல. So it will be maximum 400 milligram 3 times a day. So 2400 வரைக்கும் கொடுக்கலாம். So suppose அவ வந்து BP வந்து 400 milligram 3 times a day. No symptoms of imminent eclampsia. BP is 150/100. So what is this called? It is not severe. So what is it called? Mild kadayadu, non-severe. You classify hypertensive disorders of mild, moderate, severe la poidichu. So it is severe or non-severe. So non-severe hypertension. So ipa vandu BP vandu control illa, but romba jaasti illa, 160 110 la illa, and no symptoms of imminent eclampsia. So what will you do?
Term will wait for the termination.
Ipa vandu 35 weeks.
Yes, ma'am.
36 weeks.
One more week will wait.
So what you can do is you can start another antihypertensives like nifedipine. So you should know labetalol is the drug of choice. You should give optimum strength. நிறைய தடவை என்னன்னா 100 milligram BD கொடுத்துட்டு கேட்கலன்னு நெஃபிடபின் ஆட் பண்ணுவாங்க. That should not be the thing. You give the optimal dose. If everything is fine, probably you can add nifedipine. How do you give nifedipine?
Nifedipine IV can be given. IV is also.
சரி, நீ வந்து அந்த ப்ரிப்ரேஷன் பற்றிலாம் எனக்கு தெரியாதேப்பா. பரவாயில்ல, ஏதோ ரிசர்ச் பண்ணி என்னெல்லாமோ கண்டுபிடிச்சிருக்கா. It is only oral 10 milligram tablet, 5, 10, 20 la வருது. 10 milligram tablet we will start. Initially 10 milligram BD. TDS maximum of 80 to 120 milligram. இன்னைக்கு போய் எல்லா antihypertensive. Okay. So we were talking about medical management of hypertensive disorder, especially antihypertensives. So first we said about labetalol oral, okay. Then we talked about maximum dose. Then what is the contraindication for labetalol use? Asthma, then cardiac failure. Okay, thank you.
Cardiac failure and
Cardiac failure and asthma. So you have to specifically ask for all these things. முதல்ல பேஷண்ட்டு எந்த நோய் இல்லைன்னு சொல்லிடும். நம்ம டேப்லெட் ஸ்டார்ட் பண்ணுறச்சே அகெயின் யூ ஷுட் ஸ்பெசிஃபிக்கலி ஆஸ்க் இந்த மாதிரி ஏதாவது இருக்கான்னு. ஓகே, what is the problem with nifedipine? So what is the side effects of labetalol? Flushing varadu. Bradycardia. So we should not get worried about bradycardia. So around if the pulse, maternal pulse is around 58-60, fine. Okay. Then nifedipine, I said maximum dose is
81.
so it is a maximum of 120 milligram. What are the problems with nifedipine? So you should read up about all these things pa. இன்னைக்கு தயவு செய்து ட்ரக்ஸை போய் ஒழுங்காக படிங்க, ஃபார்மகாலஜியை ப்ரஷ் அப் பண்ணுங்க. ஸோ இதில் தான் ஃப்ளஷிங் வரும் அண்ட் ஹெட்டேக். ஸோ வாட் இஸ் த ப்ராப்ளம் இஃப் தே ஹாவ் ஹெட்டேக்? நம்ம நினச்சிப்போம் இட் இஸ் இமினன்ட் எக்லாம்சியான்னு. So you should know about all these things. Okay, you wanted to give hydrolysine illa? Tablet வந்து நான் when I was PG 87 to 89 as MD PG we had given hydrolysine tablet la we don't use much. But what about suppose if a BP is 160 110, no symptoms of imminent eclampsia, then what do you do? What is this condition called? Mic. Pa இன்னொரு மைக்கும் இருக்கா?
Hypertensive crisis.
So you will just say it is severe hypertension, severe hypertensive disorder of pregnancy. So although there are no symptoms of imminent eclampsia, you have to institute parenteral management. So how do you institute parenteral management?
Oh, IV labetalol we can give, ma'am.
Labetalol, how does it come?
First we have to start with 20.
How does it come? Ampula, viala. I want all of you all to go and see all these things. Kindly go and see. Okay.
Ampules, labetalol.
அதாவது it will come as 4 ml ampule or vial, but 4 ml வரும். Okay, so one will be 20 milligram. Each ml will contain 5 milligram. So 20 milligram. You can start off with 20 milligram. How do you give it?
Then we have to wait for 15 minutes and then 40.
எப்படி கொடுத்த முதல்ல?
IV.
IV அப்படியே புஷ் பண்ணிடலாமா? So bolus over 2 to 5 minutes. Then what do you do?
Then 40 after 15 minutes.
என்ன பண்ணுவ? So you give labetalol 20 milligram intravenously over 2 to 5 minutes. Wait for 10 minutes. Again take a BP. If BP is controlled, fine. If not, make it 40 milligram. The same way you give it as an intravenous bolus dose. Then you again wait for another 10 minutes. If still BP is uncontrolled, you can make it 80 milligram. 20, 10 minutes, 40, 10 minutes, 80, 10 minutes. Okay? Then probably you can make it 160 milligram. அதுக்கு மேலே குறையலைன்னா you have to add another parenteral antihypertensive. நீ ஏதோ ஆசைப்பட்டியே ஸ்டார்ட் பண்ணுறதுக்கு, என்னது? Hydrolysine. Okay? So how do you give hydralazine?
IV, ma'am. First we have to
You
give 5
have
to.
to be very careful while giving hydralazine because sudden fall of BP can be there, flushing can be there, patient or palpitation adallam varalam. Because it is a vasodilator. Okay, so that is very, very important. So hydralazine every 20 minutes, maximum of 30
30.
milligram you can give. Okay, அதுக்குள்ளே சரியாயிரும் பொதுவா. And when it is severe hypertension or symptoms of imminent eclampsia, you have to start Maxelf. Maxelf வந்து imminent eclampsia அல்லனா severe hypertension வந்துடுச்சுன்னா you have to give Maxelf. Why should you give Maxelf?
It will prevent seizures.
So any time patient is prone for convulsions, to prevent that you have to give Maxelf. How do you give Maxelf?
Pritchard regimen, ma'am. Loading dose of 4
How is Maxelf available?
ampules.
ஒரு ampule powder liquid see you should know all these things. You have to see மத்தியானோ எக்ஸாம்ல இதுதான்ப்பா தயவு செய்து இது பண்ணுங்க. புரியுதா?
1 gram. 2 ml 1 gram, ma'am. So 1 ampule contain 2 ml.
எவ்வளவு percentage?
Ma'am, loading dose 4
It
gram
is
of
available.
20%.
ஐயோ இப்போ எப்படிப்பா நான் காட்டுவேன்.
Pritchard regimen, ma'am. Loading dose IV, ma'am. 4 gram in 20% of magnesium sulfate, ma'am.
So what is available is 50% Maxelf. So you have to dilute it to 20%. How do you dilute?
8 ml of magnesium
So
sulfate.
it will be 4 ampules, 8 ml. That will be diluted with 12 ml of
NS.
normal saline. So you should have a 20 ml syringe in your eclampsia kit. That is most important. Examல இதுதான் கேட்பாங்க. எப்படி நீங்க dilute பண்ணுவீங்க? Then how do you give it?
Ma'am, 1 minute, 1 ml.
So you give it over about 10 to 15 minutes. At least 15 minutes, 15 to 20 minutes slow கொடுக்கணும். Okay. Then what do you do? So 4 grams of 20% Maxelf is given intravenously. This is bolus. Then
Ma'am, I am 10 gram of 50% magnesium sulfate, ma'am.
so in intravenous மட்டும்தான் dilute பண்ணுவோம். நேர IV shot கொடுக்கறதுனால you dilute it. But when you give intramuscular, you can give the 50% Maxelf itself. Okay.
In each buttocks.
So it will be 5 grams IM. That will be 10 ml in each buttock. Either you can give it as such or you can add 1 cc of lignocaine and give it. ஏன்னா ரொம்ப painful. Aseptic abscessலாம் வரலாம். Okay. But then பொதுவா நம்ம வந்து add பண்றதில்ல. Then what do you do?
Maintenance dose of 5 gram of magnesium sulfate and 50% of magnesium.
So how do you monitor?
Ma'am, knee jerk.
So you should have a knee hammer in the eclampsia kit. So knee jerk should be present. Then
Respiratory rate should
respiratory rate should be normal, more than at least 15.
Next, urine output more than 100 cc.
Urine output should be 30 ml per hour. நம்ம every 4 hours தான் கொடுக்கிறோம். So 120 ml இருந்தா பத்துன்னு கிடையாது. Hourly, so patient should be on a Foley's catheter, continuous urinary drainage. Every hour you have to see the urine output. Then in the last 1 hour at least 30 ml, 30 ml per hour. ஏன்னா ஃபஸ்ட்டு வந்து ஒரு 150 ml வந்திருக்கும். Last 1 hour kidney would have shut down. So then you have to skip the max self dose. Okay, so it's very important to monitor all these things. Then we will be giving every 4 hours. எவ்வளோ நேரம் கொடுப்ப?
Ma'am, last episode of after 24 hours of delivery and last episode of last attack.
Or last fit, whatever is later. Okay, so when you have severe hypertension, when you will start max self, you will start parenteral antihypertensives, you will think about termination of pregnancy. Since this patient is a post-cesarean pregnancy, how do you want to terminate her?
Whether she's eclamptic or LSCS, ma'am.
This, since it is a at least, so this patient recurrento, non-recurrento indication nalo, post-cesarean pregnancy with severe hypertension, better to take up for section. But maternal stabilization primarily is very, very important. Okay, so that is very, very important. So section பண்ணணும். What anesthesia will you be giving? பா அந்த என்னப்பா வேணும் அந்த பையன் செக் ஷர்ட் வெளியே போகணுன்னா போகலாம். whoever wants to go can go pa, no problem at all. attendance கொடுத்துட்டீங்க, all of you all are free to go. பிரேக்குக்கு போகிற மாதிரி போகலாம். உங்களுக்கு attendance கொடுக்கப்படும். ஆனால் அடுத்தவங்களை டிஸ்டர்ப் பண்ணக்கூடாது. and you are disturbing my flow of thought. Okay,
Neuroaxial, ma'am.
neuroaxial na என்னப்பா அர்த்தம்?
Spinal, ma'am.
So epidural or spinal. Okay, why general anesthesia cannot be given? So the thing is, either நம்ம இப்போ எல்லாருக்குமே spinal தான் கொடுக்குறோம் because morbidity will be less. When we started our career as postgraduates, as junior assistants, we used to give only general. Then ரொம்ப ஃபிட் அடிச்சுக்கிட்டே வரும். ஆந்திராலேருந்து ஐஓஜி சென்னைக்கு வரும் பேஷண்ட். அந்த காலம்லாம் ரியலி இட் வாஸ் ஹாரபிள். பேஷண்ட் வந்து இப்போ we don't see such fits at all. Everything has changed. Okay, so in that case, I mean, we used to do even under local போட்டு cesarean பண்ணியிருக்கோம். ஏன்னா ஸ்பைனல் GA கொடுத்தோம்னா they will have lot of laryngeal edema, intubation will be difficult, and while they are intubating itself, they can go in for hypertensive crisis. brainல bleed ஆயிடுச்சு, திடீர்னு hypertension ஏறும், BP ஏறும், they can go in for bleeding. Okay, we used to lose mothers like anything. Now all that has changed. You have a really nice thing nowadays. Okay, so spinal anesthesia கொடுப்போம். இப்போ வந்து இந்த பேஷண்ட்டுக்கு வந்து சிசேரியன் பண்ணும்போது now இப்போ எத்தனை வீக்ஸ் அவோ?
37 weeks and 6 days, ma'am.
இல்லை, நம்ம முதல்ல 33 வீக்ஸில் வந்தா, அதுக்கப்புறம் திருப்பி வந்தா 34 வீக்ஸில் நல்லா இருந்தா, அப்புறம் 35 வீக்ஸில் வந்தா. Okay, now only all this has happened. So is there a role? See, the baby can be preterm, but for mother's sake and even for baby's sake, because fits எல்லாம் வந்துச்சுன்னா baby will go in for fetal demise கூட வரலாம் or distress. So is there a role for antenatal corticosteroids?
Yes, ma'am. Lung maturity.
35 வீக்ஸ்லேயும் கொடுக்குறீங்களா?
Yes, ma'am.
What is the indication for antenatal corticosteroids.
Preterm baby for lung maturity, ma'am.
அதான் யாருக்கு இப்போ 35 இந்த பேஷண்ட் பேசணும். டிஸ்கஷன் வில் பி ஆன் த பர்டிகுலர் பேஷண்ட்.
Less than 32 weeks, ma'am.
So 34 weeks கீழே இருந்தா probably we can say advocate antenatal corticosteroid for promoting fetal lung maturity. ஆனால் நம்ம வெயிட்லாம் பண்ண மாட்டோம், நம்ம டெலிவரி அட்லீஸ்ட் ஒரு ஷார்ட்டாவது கொடுத்துருவோம். ஆர் கொஞ்சம் பிளட் டெஸ்ட் பண்ணி ஸ்டெபிலைஸ் பண்ணுறதுக்குள்ள வாட் ட்ரக் வில் யூ கிவ் ஃபார் லங் மெச்சூரிட்டி?
Dexamethasone and betamethasone.
What do you give here?
Dexamethasone.
Dexamethasone. So, although there are a lot of literature about betamethasone in Western literature, the salt which is found here in betamethasone in India is not similar. So, ideal would be to give a dexamethasone. What is the dose?
4 doses of 6 milligram every 12 hours.
6 milligram intramuscular every 12 hours 4 doses. ஆனால் இந்த பேஷண்ட் வெயிட் பண்ணுவோன்னு கிடையாது. இந்த சேம் பேஷண்ட் சப்போஸ் ஷி கேம் வித் imminent eclampsia at 30 weeks. 30 weeks. அப்போவும் we have to terminate pregnancy. What else will you be giving? Neuroprotection, but this max self would act as a neuroprotection too. So this is how you manage. So terminate பண்ணிட்டா இப்போ செக்ஷன் மட்டும்தான் பண்ணுவியா, ஸ்டெரிலைசேஷன் பண்ண வேணாமா செகண்ட் சைல்டு? பேஷண்ட் சிக்கா இருக்கும்போது பண்ணலாமா?
No.
So generally when patient is critically ill, we are not supposed to do sterilization. Patient settu pochina, sterilization death is viewed very seriously. We have to give compensation. ஆனால் நம்ம வந்து எழுதி வாங்கிட்டு பண்ணலாம். ஸ்டெரிலைசேஷன் சின்ன ப்ரொசீஜர். ஸ்டெரிலைசேஷன் எல்லாரும் பார்த்துருக்கீங்களாப்பா? எல்லாரும் பார்த்துருக்கீங்களா? தயவுசெய்து ப்ரொசீஜர்ஸ் ஓடி போய் பாருங்கப்பா. தயவு செய்து போய் பாருங்க. யூ ஆல் ஹாவ் டு see, read up and come see the cases. Nobody will call you. இங்கே உங்களுக்கு ரொம்ப ஃபீட் பண்ணுறாங்கப்பா. எனிவேர் nobody will bother. இது வந்து உங்கள் கவுண்டர் பார்ட்ஸ் இருப்பாங்கல்ல, இந்த அளவு எடுக்கிறாங்களா? Wardla maybe I don't know, but generally too much care is, you all have to go and see cases. When you don't have cases, அப்பப்போ பண்ணுறாங்க. இந்த பசங்க பண்ணிகிட்டே தானேப்பா இருக்கு. சிசேரியன் பண்ணாங்கன்னா ஸ்டெரிலைசேஷன் பண்ணுவாங்க. கைண்ட்லி கோ அண்ட் see. So they will ask you, you can argue it in any way. Since patient insisted this is not going to cause harm, probably I will do. But actually, in a critically ill patient who might go in for, who might even die, we are not supposed to do. Okay? So, post-op enna பண்ணுவ? Post-op enna பண்ணுவ?
Monitoring.
Monitoring enna monitoring? எப்படி பாப்ப?
Vitals, blood pressure should be monitored again.
Blood pressure. So you have to continue max self 24 hours after delivery. You have to continue antihypertensives. Antihypertensive requirement will come down. Probably you can put them on oral antihypertensives. It can be labetalol, it can be nifedipine, or it can be even other things like other adala use pannalam. Okay? And breastfeeding should be initiated. You have to repeat the blood investigations on day 3, because even now patient can go in for HELLP syndrome. 1/3 of HELLP syndrome is postpartum. Okay, so because of that you have to evaluate, but the requirement of antihypertensives will come down. Then once settled, you can discharge the patient on antihypertensives if need arises, but you should ask her to come back after 1 week or even after 3 days, that she can have a BP elsewhere and again review. So when her BP becomes less than 130/80 postpartum, you will bring down the hypertensive dose. Okay, and 1 week later also you have to check for urine albumin, all those things. Then you have to evaluate the, you can put them on antihypertensives, or if the BP becomes normal, no need for antihypertensives. Again, you have to start her on contraception. Sterilization பண்ணிட்டா okay. அல்லனா என்ன பண்ணுவ?
Copper tea.
If patient does not want them, copper tea. So what is it called?
IUD, intrauterine
It
contraceptive
is
device.
called as post-placental insertion. You remove the placenta immediately during C-section itself. You are inserting the IUD under vision. Open பண்றோம், then IUD இப்படி gloves போட்டுட்டு தான் இருப்போம். IUD உள்ள வச்சிட்டு then you suture. Okay, so that will be there. That is called as post-placental, PPIUCD. Okay, so அது பண்ணலாம். Or else at 1.5 months, when she comes for review, you can consider contraception. Okay, it can be what other contraceptives can be given?
OC pills.
OC pills 6 weeks la kudukka maatom. Ena mother will be breastfeeding her child. You can probably start at 6 months, but not earlier. Okay, nama vandu medroxy what is the progesterone which is given? Pardon? 17 hydroxy, what else?
Medroxy progesterone.
Acetate, how many milligram?
150
150 milligram intramuscular, can probably given at 6 weeks when she comes for review. Okay, and at 6 weeks again you have to repeat the blood investigations like kidney function, liver function, urine protein. If still it is present, probably now you will send her for consultation to a physician. If everything is fine, again you will see at 12 weeks and decide about what category she really comes into. Whether it is gestational hypertension, whether she is pre-eclampsia, or whether she is chronic hypertensive. When will you say patient is chronic hypertensive?
If blood pressure persists after 12 weeks of
Very good. One thing, she would have had a previous history of hypertension, or probably if she develops hypertension very early, first visit le hypertension irukku, avalukku theriyala, probably she is hypertensive. Or if BP persists even after 12 weeks, that means she is a chronic hypertensive. When do you say she is a gestational hypertension?
when BP comes to normal after 12 weeks of delivery.
So she had developed hypertension 20 weeks after pregnancy. She did not have any other system affection in the form of proteinuria or abnormal renal function, abnormal liver function. Then at 12 weeks, she was found to be normotensive. Her other parameters are also normal. When do you say preeclampsia?
Presence of proteinuria or signs of end organ damage.
So she developed hypertension 20 weeks after pregnancy, she either had proteinuria or other organ affliction in the form of abnormal liver function test, abnormal renal function test, cardiac involvement, neurological involvement, lung involvement, or abnormal hematology. Then at 12 weeks, she is found to be normal. So that means it is hypertension which has developed because of pregnancy, but we call it preeclampsia because there is other organ dysfunction. Puriyudha? Okay. So in the patient, 12 vaarathla she is coming to us. Then what do you tell her?
Again, we have to check her BP, and if it's normal.
Everything is normal. Ipa normotensive. But you should know that this patient, her life is reduced by 10 years. Just because they develop hypertension in long-term sequelae, nammalukku theriyanum. So, இப்ப நார்மலா இருந்தாலும் she has 10 years mortality, 10 years of her life actually decreases. But அது நம்ம சொல்லணும்ல, we can tell her she is prone for cardiac disease. She is prone to develop hypertension. So, அதை எப்படி prevent பண்ணணும்? நம்ம optimum weight இருக்கணும். She was overweight. BMI of 27 or
26.
So you should tell her she should really lose weight, maintain nalla activa irukano, keep, and yearly lipid profile should be checked. Every year BP should be checked, and she should maintain an optimum BMI. So idella nama solli anupanum. Suppose she is a primigravida, then she would have delivered. We should tell her that in the successive pregnancy also, she is prone to develop hypertensive disorder of pregnancy. So we have to be, she should know that nichya varunu kadayadu, but tendency is high, and she should be put on 150 milligram aspirin from 12th week onwards. இதெல்லாம் நம்ம சொல்லி அனுப்புனாதான் அடுத்த இதில் மிஸ் ஆகாது. So all these things are very, very important. Okay. Today, any doubts? இல்லை. Very clear. So today you kindly go and read up. நீங்கள் எல்லாருமே ஒரு கிளினிக் புக்கு வச்சுருக்கீங்கல்ல, அதையும் போய் படிங்க. அப்புறம் உங்கள் தியரி புக்கும் படிச்சிருங்க. Because then only you will have doubts. And we have analyzed all sorts of situations. HELP syndrome வந்து, what is HELP syndrome?
Hemolysis, elevated liver enzymes, and low platelet count.
So it is essentially a lab diagnosis. That is the reason why I say that even if the BP is normal, you should keep on repeating the lab parameters. Suppose if it is well controlled every week, otherwise once in 3 days. Okay. Postpartum nichyo day 3 எல்லாத்தையும் பார்க்கணும். And there is, what is postpartum hypertension? There is a definite entity known as postpartum hypertension where people antenatally they will be fine, intrapartum they will be fine, but postpartum within 10 days after delivery they can develop hypertension. So நம்ம வந்து monitor பண்றது very, very important. And இந்த பேஷண்ட்ஸ்க்கெலாம் வந்து இப்போ சிசேரியன் செக்ஷன் வந்தால் பண்ணியிருக்கேன்ல, என்னெல்லாம் ட்ரக்ஸ் கொடுப்ப?
Anesthesia, spinal anesthesia.
கேஸ் ஷீட்டை பார்க்கணும்ப்பா. இன்வெஸ்டிகேஷன் சார்ட் மட்டும் பார்த்துருக்கீங்க, கேஸ் ஷீட்லாம் பார்க்க மாட்டிங்களா? வாட் எவர்.
Prophylactic antibiotics.
Okay, then? IV fluid. This patient, she will be grossly edematous, but her intravascular volume will be contracted. So, நம்ம IV fluid வந்து மற்ற patients மாதிரி 150 ml per hour வேகமாக கொடுத்தோன்னா she will develop pulmonary edema. You will not give IV fluid more than 75 ml per hour. So, any PIH patient, you have to tell, that is, be wary of IV fluids. Okay? That's very, very important. And you will be giving analgesics for hypertensives. So, enna aguna, especially patients who are prone for hypertensive disorder of pregnancy, or patient who has had mild hypertension, persist agum, or postpartum hypertension develop agalam. So, NSAIDs, non-steroidal anti-inflammatory drugs for analgesia kudukradhukku padala, probably you can give paracetamol like that. What are the examples of non-steroidal anti-inflammatory drugs?
Aspirin, ibuprofen.
So, ibuprofen, அதெல்லாம் வந்து நம்ம naproxen sodium. So, அதெல்லாம் that will persist the cause persistence of hypertension. Do no harm. That is very, very important. யோசிச்சு இதெல்லாம் பண்ணணும். Okay. Thank you. Any doubts, ma? Any doubts? Grades of edema படிக்கணும். Grades of proteinuria. இதெல்லாம் போய் prepare பண்ணுங்கப்பா. Grades of proteinuria படிக்கணும். Medicine-க்கு they helpful. Then grades of retinopathy. Okay. Then medical management, oral drugs. நம்ம வந்து என்ன ட்ரக்ஸு என்ன இது இப்போ ஆல்ஃபா மீத்தைல் டோப்பானா இட் இஸ் சென்ட்ரலி ஆக்டிங். இது லெபிட்லால்னா இட் இஸ் selective beta blocker. So, like that you should be able to tell. Nifedipine is calcium channel blocker. Dose enna? Appo, what are the contraindications? What are the side effects? So, இது எல்லாம் போய் max self அது மாதிரி தான். Antenatal corticosteroids, then magnesium sulfate for neuroprotection. Then what is the contraceptive of choice in இது? So, any patient, antenatal patient na இப்படி தான். And whether next pregnancy is permitted, all these things you have to. Okay. Thank you.
Thank you.
ரொம்ப கிளாப்ஸ் கிடைக்குது. வெரி குட்.
And what is the cause for PH? So that as you told in next pregnancy, aspirin can be taken. Even in ultrasound in primary pregnancy, uterine artery Doppler will indicate that patient will be prone for PH.
இதுதான் நான் சொன்னேன் இல்லையா, ஜெஸ்டோசிஸ் ஸ்கோர். I spoke to the people who have posted in OG. So, ஜெஸ்டோசிஸ் ஸ்கோர், ஃபாக்ஸி ஜெஸ்டோசிஸ் ஸ்கோர் இன்னைக்கு போய் படிங்க. ஓகே, ஒவ்வொரு விசிட்லேயும் இட் கன்சிஸ்ட் ஆஃப் 27 காம்பனன்ட்ஸ். 27 நட்சத்திரம் இருக்கு இல்லையா, அது மாதிரி 27 காம்பனண்ட் இருக்கு. அதில் சிலதுக்கு வந்து 1 மார்க், சிலதுக்கு 2 மார்க்ஸ், சிலதுக்கு 3 மார்க்ஸ். பாஸ் ஹிஸ்ட்ரி ஆஃப் ப்ரீ எக்லாம்சியானா அதுக்கு வந்து 3 மார்க்ஸ். ஐ மீன் இஃப் க்ரானிக் ரீனல் டிசீஸ் இருந்தால் 3 மார்க்ஸ். ஸோ 3 மார்க்ஸ் வந்தால் யூ வில் ஸ்டார்ட் லோ டோஸ் ஆஸ்பிரின். ஓகே, ஸோ ஒவ்வொரு விசிட்லேயும் பார்க்கணும். அண்ட் சிஸ்டரே யாராவது டிக் பண்ணலாம். ஸோ இட் இஸ் அ டைனமிக் திங். முதல்ல வந்து நார்மலாக இருப்பா, இப்போ வந்து திடீர்னு வந்து அவள் வந்து hypothyroidism develop பண்ணானா her score will increase. So each visit we have to see.
Then mainly about drugs, route, mechanism of action. Then about dipstick picks up how many milligrams of protein.
Very important. Proteinuria எல்லாம் போய் ப்ரிப்பேர் பண்ணிட்டீங்க. இன்னைக்கு பண்ணிட்டீங்கன்னா உங்களுக்கு வந்து எக்ஸாம்க்கு நேராக நீங்கள் போகலாம். ஹைப்பர்டென்சிவ் டிஸார்டர் அடிக்கடி வைப்பாங்க. வைக்கிறது ஈஸி டு ஹேண்டில், உங்களால் மேனேஜ் பண்ணுறது ரொம்ப ஈஸி.
And risk factors for PAH. Whenever patient comes to OPD, they have to concentrate on that.
யாராவது போய் பார்த்தீங்களாப்பா ஃபாக்ஸி ஜெஸ்டோசிஸ் ஸ்கோர்? நான் அந்த அந்த பசங்கிட்ட சொன்னேனே, இங்கே உட்காந்துருக்காங்களே, யாராவது பார்த்தீங்களாம்மா? பார்க்கல. யாராவது ஒரு ஜீவன் பார்த்துச்சாப்பா? அதுதான் உங்களுக்கு ஆப்பர்ச்சுனிட்டிஸ் தெரியல. எங்களுக்கெல்லாம் தேர் வர் நாட் பீப்புள், ஏன்னா ஆல் வேர் பிஸி டூயிங் ஒர்க்.
Patient load, ma'am.
ஆமாம், பேஷண்ட் இது உங்களுக்கு வந்து அந்த இது தெரிய மாட்டேங்குது, கப்புன்னு பிடிச்சிக்க.
Then counseling regarding the patient, as madam told, either for a P1 L1 or for a patient who completed, because her longevity decreases by 10 years, you have to tell that she should check up BP. In case they become hypertensive, she has to take treatment. That's all, ma'am.
ஓகே, தேங்க்யூ. அடுத்த கேஸ் என்னப்பா? வா. ஃபைப்ராய்ட்.